Hello, Ria. Hello, Nibeda. Hello.
Yes.
Able to hear me, Ma?
Yes, ma'am, I'm able to hear you, ma'am.
Yeah, you can start with something.
Good morning, ma'am.
Good morning.
Uh, I'll be presenting a case on antepartum hemorrhage, ma'am.
Okay.
Mrs. Vidya, a 28-year-old female, wife of Mr. Kanlin from Rayapuram, who's a housewife by occupation and has studied till 10th standard, belonging to upper lower class 4, uh, uh, with last menstrual period on 3/10/2020 and expected date of delivery on 10/7/2021, and an obstetric code of Gravida 2, Para 1, and Live 1. Came with complaints of bleeding per vagina 2 days ago and history of 9 months of amenorrhea. History of presenting illness. The patient was apparently normal 2 days back. Then she developed bleeding per vagina,
One
which
minute.
was sudden in onset, completely soaks one pad, associated with
Nibeda.
bright red color.
Hello,
Yes,
Nibeda.
yes.
1 minute. Are you able to hear, ma'am?
I'm able to hear, but
Uh,
Niveda is not hearing me.
okay. I think mic some
Hello.
problem with this. Hello. You are not able to hear.
I'm able to
Hello.
hear.
No, actually I was talking in between, Ma. We were not able to hear, no?
Okay. Yes, ma'am. I think mic this pen is not working. Hello, Niveda. Hello.
Yes.
Are you able to hear me now?
Yeah, I'm able to hear you, but it's a bit less louder than before.
Just louder. Okay. Hello. It's 1 minute. Hello, Niveda.
Yes. Now it's audible.
But I'm not able to hear.
Double it's there.
I think we have to move something here.
Here, ma'am. Actually, we are speaking through here. It's getting heard over
Echo,
there.
yeah.
Fine, we will do one thing. We can okay, we'll fine, do one thing. We'll off the mic. That's the audio. having. Ma'am, is it okay? You can see the screen, ma'am, but I think it won't be visible from Ah, yes, ma'am. No, we can mute this speaker.
Hello?
No need of this. Hello, Niveda, are you able to hear me now?
Yeah, I'm able to hear. Can I continue, ma'am?
Okay, we'll use this here first.
Hello, Niveda.
Yes, ma'am. Yes, ma'am.
Able
Uh,
to hear me well?
yes, ma'am. Yes, ma'am. It's clear now. Very clear.
Okay. Yeah, yeah. Okay. From the history, from the starting. Okay.
Okay,
You
ma'am.
you go back to your history. You g- you go back to your presenting complaints.
Okay, ma'am.
Even prior to that, see how many days is over in your OG posting?
Around 2 weeks, ma'am.
2 weeks. Okay.
Yes,
Previous
ma'am.
slide, first slide. Go back to your first slide.
Yes, ma'am. I've changed it, ma'am.
See, whenever you start presenting, after the
Yes, ma'am.
name and socioeconomic class, you have to tell about the
Yes, ma'am.
obstetric code.
Okay, ma'am.
Okay, you don't
Okay, ma'am.
mention as obstetric code.
Okay, ma'am.
Belonging to so and so, belonging to class 4 socioeconomic status, a gravida 2, para 1, live 1, with so many months of amenorrhea,
Okay, ma'am.
with LMP on this date, EDD on this date, and you have to
Okay.
mention whether she is a booked or an immunized patient also. In your
Okay, ma'am.
first line itself, all these details should come.
Okay, ma'am.
Okay. After that,
Okay.
next slide.
Mm.
You You check, no, previous one. In the chief complaints, you have to say about the history of amenorrhea first. After
Okay, ma'am.
after saying about that she has come with history of 9 months amenorrhea and bleeding PV for so many days.
Okay, ma'am.
Because if you're not saying about the history of 9 months amenorrhea is important here. It's an obstetric case. Otherwise, if you simply say as bleeding per vagina, then it becomes, we'll be thinking that it is a gynec case.
Okay, ma'am.
Am I right?
Yes, ma'am.
Yeah, yeah. So, okay, present again. Come out again.
Yes, ma'am. Mrs. Vidya, a 28-year-old female from Rayapuram who's a housewife by occupation, belonging to upper lower socioeconomic class, with gravida 2, para 1, live 1, last menstrual period on 3/10/2020, with 9 months of amenorrhea, and expected date of delivery on 10/7/2021. Presented with
Yeah.
complaints of
Booked and
9
immunized. Whether
months.
she is booked
Yes,
and
ma'am.
immunized.
Yes, ma'am. She was booked and immunized at RSRM.
Mm,
She
okay.
presented with complaints of history of 9 months amenorrhea and bleeding per vagina 2 days ago.
Okay. Okay. Go ahead.
History of presenting illness. The patient was apparently normal 2 days back. Then she developed bleeding per vagina, which was sudden in onset, completely soaks one pad, associated with bright red colored blood. It stopped spontaneously. Fetal movements were well perceived. No history of pain in abdomen
Wait, wait,
associated
wait,
with
wait.
bleeding.
Wait. She developed bleeding per vagina, which was she soaked one pad, and after how many hours of bleeding, the bleeding stopped.
Not sure, ma'am.
You have to ask that.
Okay,
Because,
ma'am.
because in a pregnant patient at 9 months amenorrhea, and mostly they'll be coming off immediately to the hospital. They'll not be waiting for 2 days. Is it not?
Okay, ma'am. Yes,
So
ma'am.
you, from where did you take the history? You were giving it?
Senior came from senior.
Senior.
Who is the senior?
Senior batch, ma'am. Last year,
Ma'am,
this year,
Last year
2025.
batch.
Yes, ma'am. They are coming back.
Okay, okay. Actually, for whenever a patient with pregnancy, if she bleeds, they'll be coming off immediately. They'll not be waiting for 2 days and all. Okay, you
okay.
take it as she has bled, that too at 9 months amenorrhea. It might be because of labor also, is it not?
Yes,
So
ma'am.
they'll not be waiting. So they'll come off immediately. Okay, go ahead.
Fetal movements were well perceived. No
Go
history
ahead.
of pain in abdomen associated with bleeding. No history of similar episodes previously. No history of excessive fatigability or palpitations. No history of blurring of vision or pedal edema. No history of abdominal trauma. No history of leakage of fluid per vagina. History of present pregnancy. It was a spontaneous conception. She was booked and immunized at RSRM, 2 doses of TD given at third and fifth month, first trimester. Pregnancy was detected by urine pregnancy test at RSRM hospital after 4 weeks of missed period. No history of excessive vomiting, fever with rashes. No history of burning menstruation. No history of spotting or bleeding per vagina. No history of exposure to radiation or no history of drug intake. Folic acid tablets were taken. Dating scan was done at third month. Second
Okay.
trimester, quickening was felt at fifth month. No history of headache, blurring of vision, or pedal edema. No history of bleeding per vagina. No history of polyuria, polydipsia, and polyphagia. No history of burning micturition. Iron folic acid and calcium tablets were taken. Anomaly scan was done at fifth month. Uh, Anomaly scan showed normal development. Placenta was located anterior and it was encroaching on the internal os.
Okay.
Third, third trimester, fetal movements were well perceived. History of bleeding per vagina. No history of abdominal pain. Iron folic acid and calcium tablets were taken. USG done at 32 weeks showed normal fetal growth. Placenta was anterior and implanted in the lower segment, reaching up to the internal os. Grade 2 maturity. No evidence of retroplacental hemorrhage seen.
Okay.
Menstrual history. She attained menarche at 13 years. Last menstrual period was on 3/10/2020. It was a regular 4 days flow for 28 days cycle. Moderate flow, it was not associated with pain or clots. Marital history. She was married at 22 years of age, non-consanguineous marriage, and no contraceptives were used. Past
Okay.
obstetric history. She's a gravida 2, para 1 and live 1. First pregnancy was conceived at 24 years. First, second and third trimester were uneventful. Elective cesarean section due to breech presentation at 39 weeks in RSRM hospital. She delivered a female baby weighing 3.5 kgs and it cried immediately after birth. Post-operative period was uneventful.
Okay.
Past history. The history of elective cesarean section at RSRM hospital 4 years back. She's not a known case of diabetes, asthma, hypertension, TB, epilepsy, and thyroid disorders. No history of previous blood transfusion.
Okay.
Family history. No history of bleeding disorders in the family. No history of chromosomal anomalies or birth defect in family. No history of twin gestation in family. No history of preeclampsia in mother and siblings.
Why do you want to ask about twin gestation in the family? Why do you want to ask about twin gestation and chromosomal anomalies or birth defects in family history in this particular case? Is there
I'm
any
not sure.
significance? See, you cannot be presenting everything in all the cases. Only
Okay.
relevant points you have to present.
Okay.
Is there any relevance to your particular case for twin gestation and chromosomal anomalies and birth defects? Yes,
No.
history of bleeding disorders. Yes, because she has she come with
Bleeding
the
pattern.
complaints of bleeding PB. Even preeclampsia, how is it important? There is a
Ma'am,
significance, but how?
if uh, she also has preeclampsia, then that she has a higher risk of abruptio placenta, ma'am.
Yes, that will present as antepartum hemorrhage. But
Antepartum hemorrhage.
what is the significance of present talking about chromosomal anomalies and birth defects twin gestation?
It should not be there.
Yes, it should not be there. There is no significance at all. You should not be presenting everything in all the cases and ask the examiner to pick up the points whatever they want. You have to, you are, after this examination, you are going to be a consultant, a graduate. So you should be able to pick out the relevant points and present. Okay?
Okay.
Yeah,
Okay.
go ahead.
Personal history. She consumes mixed diet, normal appetite, sleep pattern normal, normal bowel and bladder habits, no history of smoking or substance abuse, no history of any drug allergy.
Yes.
General examination. She was conscious, oriented, moderately built, and afebrile. No pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy. Her height is 157 centimeters. Her pre-pregnancy weight was 64 kgs. Her BMI is 25.96, and her current weight is 73 kgs. Weight gain during pregnancy is 9 kgs.
Okay.
Vitals, her blood pressure was 130 upon 80 millimeters of mercury, measured from left arm in sitting position.
Mm.
Pulse 76 beats per minute, and respiratory rate 16 per minute.
Okay.
Breast, spinal, thyroid examinations were normal.
Mm.
CVS S1, S2 heard, no murmur and no added sounds. Respiratory
Ah,
system, normal vesicular breath sounds, no added sounds. And no CNS, no focal neurological deficit.
okay.
Abdominal examination. On inspection, the uterus was longitudinally distended. Linear nigra and stria gravidarum were seen. A healthy transverse cesarean section scar, 2 centimeter above the pubic symphysis, was seen. All quadrants move equally with respiration.
Okay.
Palpation. Fundal height corresponds to 36 weeks of gestation. Symphysis fundal height is 36 centimeters and abdominal girth is 99 centimeters. Uterus
Okay.
is not tense, not tender. Fundal grip shows a broad, soft mass, which is suggestive of fetal breech. Umbilical grip on the left side shows a uniform curved, continuous curved resistance, which is suggestive of spine. On the right side, irregular knob-like structures were felt, which is suggestive of limb births. First pelvic grip showed a hard, round, and independently palatable mass occupying the lower pole of uterus, which is probably fetal head. Second pelvic grip, fingers were converging, which suggests that head is not engaged. On auscultation, fetal heart sounds were heard in the left spino-umbilical line. Fetal heart rate was 140 per minute.
Okay.
Diag- Diagnosis, Mrs. Vidya, a 20 years old female with gravida 2, para 1, live 1, with 36 weeks of gestation, with last menstrual period on 3/10/2020 and expected date of delivery on 10/7/2021, who on examination revealed a single live fetus in cephalic presentation with good fetal heart sounds, is a case of antepartum hemorrhage, that is placenta previa, under evaluation.
Okay. Actually, in your examination, you will not be given any ultrasound finding. The
Okay,
patient
ma'am.
will not be able to tell the ultrasound findings to you. Is it not?
Okay. Yes,
So
ma'am.
you forget about the ultrasound finding.
Yes, ma'am.
Oh, huh? And no case records will be given to you in your examination. Only the patient with the history. And
Okay, ma'am.
none of her documents will be given to you. And so you will not be knowing about the ultrasound finding. So in
Yes,
this
ma'am.
case, you forget about the ultrasound finding. And now, patient, a gravida 2, para 1, live 1, previous cesarean section, at 39 weeks of gestation has presented to you with bleeding TB.
Yes, ma'am.
Okay, a case of antepartum hemorrhage. How will you proceed?
Ma'am, first we will take the general
One minute,
investigation.
ma. I think we can close this. You close off this screen. No
Okay, ma'am.
screens sharing.
Okay, ma'am.
You-
She is only
no, let her. Let us not see this.
okay.
You just take off this and you
Ask her to present directly.
present directly.
One
Present
minute, ma'am.
directly, ma. You switch on your video.
Ma'am, 1 minute, ma'am. I'll get cut from the call if I switch on the video. I'll come back to the call in 1 minute, ma'am.
Yeah. ಅದೇ video on பண்ணிட்டு. Yeah. Otherwise, it will be a monotony.
Sure.
Even all the others can also switch on the video, no?
Yes, sure. Ask.
Only audio
Hello.
they can switch
Hello. I
it
think everyone can also switch on your videos. Hello. Hello.
mic மட்டும் mute பண்ணிட்டு
It's not. The laptop is not working.
no, not us,
Yeah.
all the others.
Hello, ma'am.
Yeah, muted them. Otherwise, it will be echoing.
No, videos.
Video we cannot. I think she has put the video present on.
Yeah.
Rest of you can also on your videos.
You gotta ask your friends to switch on the videos.
Guys, come on. Some of you switch on, no? Nikalya, Nitula.
We should see whether they are there or not.
Ma'am, they're there.
We have started.
I
Subda.
can do. Ask the rest of them also to switch on the videos, ma. To mute the audio alone and
Yes,
switch
ma'am.
on the. Otherwise,
Guys,
it will be monotony.
everyone switch on your videos, no?
Yeah. Or else I'll take a photograph of this presentation and send it to your dean if we have to continue the classes.
Shine.
Only are there.
This is myself.
Yeah. 43 others are there. 42 others are there. Huh?
Almost everyone.
Okay. Now, if Niveda is not able to answer, the others, whoever knows the answer, can switch on the mic and answer. Okay? Okay, Niveda, how will you proceed in this particular case?
Ma'am, we do the routine blood investigations, ma'am.
Huh?
This coming through
Routine
the
blood investigations, ma'am.
This will be. Yeah, okay. Yes, routine blood investigations.
Complete blood count, blood grouping, RH typing, bleeding time, clotting time, prothrombin time, activated partial thromboplastine time.
Wait. Now she has come with fresh bleeding TB.
Yes, ma'am.
Okay? Not history 2 days back. She has
Okay.
come with bleeding PB, 9 months amenorrhea, and now she is bleeding. What will you
Yes,
do?
ma'am. We'll
You'll
first
not be going
manage
and
the
taking the investigations leisurely. It's an
man.
obstetric emergency, is it not?
Yes, ma'am.
Yeah.
We'll first manage the bleeding, ma'am. We'll insert IV lines and we'll give fluids. IV crystalloids will be given.
You will start an IV lifeline.
IV line.
One line is not sufficient. An obstetric hemorrhage, definitely you will need two IV lifelines.
Two IV lines,
Okay,
yes, ma'am.
two IV lifelines you have to start. Okay,
Yes.
after that,
After that, we can collect blood for all these investigations, ma'am.
yes,
And we can do, once the bleeding is controlled, we can do an ultrasound
bleeding is not at
transfer.
control. Bleeding is not at control, and you have just put on a line, and nothing else you have done. What else you have collected for the blood investigations? What else you should do to the patient? So yes, now you have to ask for the records what she has, because will you do a pervaginal examination or not?
No, ma'am, we can't do a proper vaginal examination.
Why?
Because in placenta previa, if we accidentally touch the existing placenta, it may lead to hemorrhage, ma'am.
Yes.
Uncontrollable bleeding.
Yes, for that, what will you do? But in abruptio placenta, what are all the differential diagnosis for antepartum hemorrhage?
Ma'am, there can be placental causes like abruptio placenta, placenta previa,
Ah,
and there can be fetal causes like vasa previa,
ah,
and there may be cervical polyps, cervical carcinoma,
ah.
and
Okay,
there may be circummarginate placenta.
okay. So the major two causes are abruptio placenta and placenta previa, and the others is anomalies in the placenta and any abnormalities in the cervix and vagina. Even a vaginal infection, yes, it might also present with antepartum hemorrhage.
Yes,
Okay,
ma'am.
okay. What is the management in abruptio placenta?
Ma'am, in abruptio placenta, we go for active management, ma'am. We immediately conduct delivery, ma'am.
So then should you do a pervaginal examination or not?
Uh, yes, ma'am.
You have to, is
Yes,
it
ma'am.
not?
Yes, ma'am.
So,
We can do pelvic examination in OT.
huh? Why should you
Pelvic
go to
examination.
OT? You have to ask for all the records, ultrasound records, which she is having previously.
Okay.
Okay, you have to review the records, and now after your examination, everything is complete. Now you have to do an ultrasound in your casualty itself to rule out
Okay.
any placenta previa.
Okay.
So, okay, now in your case, the placenta is fundal anterior.
Okay.
Everyone, please switch on your videos, and others also should answer. All others, please switch on your videos, and you people should also answer. If Niveda is not able to answer, the others. Okay. Ask them, no?
Hope we can speak, ma'am. Hope everyone can switch on your videos.
Okay. Okay. Now you have to do an ultrasound examination. And in
Yes, ma'am.
ultrasound, what are all the things you will see in this particular patient?
We can see if the placenta is in the lower uterine segment or in the upper uterine segment, ma'am.
Okay. Then,
And if there's a retroplacental clot present or
Okay.
not.
Then, simultaneously, you have to monitor see about the fetus also. What is
Yes,
the
ma'am.
dreaded complication in abruptio placenta and placenta previa if the bleeding is heavy?
Fetal insufficiency and death.
No, if the patient bleeds heavily, even the fetal heart FH might also disappear.
Go down.
Baby
Yes, ma'am.
might go in for an IUD also. So you
Yes,
have to
ma'am.
take this as an opportunity to see whether the patient baby is alive or not. Okay,
Okay.
okay. In case the placenta is fundal, then how you will proceed? You have to rule out an abruption in this patient.
Yes,
And
ma'am. Abruption.
also, this particular patient is a case of previous cesarean section.
Yes, ma'am.
Then one more differential diagnosis in this is scar dehiscence and
Placenta.
uterine rupture.
Yes, ma'am.
Is it not?
Yes, ma'am.
So that is also one of the reasons for antepartum hemorrhage in this particular patient. So you have to do a pervaginal examination to see whether she is in labor, whether there
Okay.
is any evidence of abruption, and
Yes, ma'am.
how will you differentiate between abruption and placenta previa, except for other than scan finding?
Placenta previa will usually be a painless, causeless bleeding, ma'am. Whereas
Okay,
abruptio placenta will usually be associated with abdominal pain.
okay.
And in abruptio placenta, the fundal height will be higher than the gestational, will not correspond to the gestational age. It will be higher than the gestational
It's
age.
not necessarily, it might be bigger than the period of gestation. Then,
Yes, ma'am. And then pain will be always present, ma'am. And
okay,
uterus will be tense and tender in abruptio placenta, whereas in placenta previa it will not be tense and tender. And mostly
okay.
fetal heartbeats will be heard in placenta previa, and it may not be heard in abruptio placenta.
No, no,
And
no, no. Only it depends upon the severity of abruption.
okay,
What are all the degrees of abruption?
uh,
Grades of
uh,
abruption.
4 grades of abruptions, ma'am.
Ah,
Grade 0, 1, 2, and 3.
ah.
Grade 0, post delivery, retroplacental clot will be seen. So it can be diagnosed only after delivery.
So abruption is detected only after
After delivery of the
delivery.
placenta.
Delivery only after delivery we'll be able to know whether, that the patient has gone in for abruption.
Abruption.
That too only by detecting a retroplacental clot. That is
Yes, ma'am.
grade 0 abruption. Okay.
Yes, ma'am.
Grade 1.
Grade 1 will be pain preceding the mild vaginal bleeding, ma'am. The mother and fetus will be stable. And
Ah.
in grade 2, yes, ma'am.
So grade 0 is concealed hemorrhage and grade 1 is revealed
Mild
hemorrhage.
revealed hemorrhage.
Revealed. The
Yes,
hemorrhage will be revealed. So
yes,
you'll
ma'am.
be able to diagnose even before delivery in the
Yes,
antepartum
ma'am.
period itself. Is it not?
Yes, ma'am.
Okay. Grade 1.
Grade 1,
Sorry,
I just
2.
said.
Grade 2.
Grade 2, the vaginal bleed will be mild to moderate, ma'am. The
Uh,
fetus will undergo distress, whereas the mother will be stable.
so there will be fetal distress. Okay. Grade 3.
Grade 3, both the mother and fetus will undergo distress, and there may be intrauterine death of fetus, ma'am, and there will be
Fetus
very heavy bleeding.
also. So, only in your grade 3 there is IUD.
IUD.
Otherwise, in all other grades, the baby will be fine only. Is it not?
Yes,
So,
yes,
for differentiating, you need not say as that the baby will go in for an intrauterine demise.
yes, yes.
Okay. So, what are all the types? So, this is as far as abruption is concerned. You are talking about the grades of abruption. What whereas in placenta previa it is types,
Types.
types of placenta previa. What are all the types?
There are type 1, 2, 3, and 4, ma'am. Type
Uh,
1 is when the margin of the placenta is within 2 centimeters of the internal os.
okay,
Uh, Type 2
it
is
might
when
be anterior or posterior.
posterior. It may
The
be anterior.
placenta might be in the anterior wall or posterior wall,
Posterior.
but it is within 2 centimeters of internal loss.
Internal os.
Okay, then
Second is the marginal placenta previa, ma'am. This is
yes,
also, and this may also be anterior or posterior.
uh,
The placental margin will touch the internal os margin in type 2.
internal loss. It will be touching the internal loss. It will not be covering the internal
And then,
loss. This
yes,
is type
2.
2. Okay. What is type 3?
Type 3, the internal os might be partially covered with placenta, ma'am. And in type 4, the internal os will be fully covered by the placenta.
It is central placenta previa.
Central.
Okay. In this, where you can allow a vaginal delivery. Is there any role for vaginal delivery in placenta previa?
Yes, ma'am. In type 1 anterior and type 2 anterior, trial of vaginal delivery may be tried.
Type 1 anterior or posterior, both the things you can allow a vaginal because it is 2 centimeters away from the internal os.
Yes.
Okay, it is not touching the internal os. And in type 2 anterior, again, you can
We
go for,
can try vaginal delivery trial.
you can allow a vaginal delivery. In type 2 posterior and type 3 and 4, there is no role for vaginal delivery at all. Okay, so here after doing an ultrasound examination, you will be knowing whether the placenta is in the lower segment or whether it is in the upper segment. If it is not a placenta previa, you have to go ahead and do a pervaginal examination to see the status of the patient, whether she is in labor, whether there is any evidence of the rupture uterus, and or whether there is the severity, whether there is any evidence of abruptio placenta, and if there is any abruption, the severity of the abruption. Okay, this is how you have to proceed whenever a patient with history, patient in antepartum period, whenever they come with history of bleeding PV. And what other differentiating points are there between abruptio placenta and placenta previa?
Uh,
One is
the
painless bleeding,
Yes, ma'am.
uh,
And
and then
fetal parts. Malpresentations are more common in placenta previa as compared to abruptio placenta, ma'am.
yes, because the placenta is occupying the lower uterine segment. The malpresentations are common. Yes, then
And the maternal hemodynamic instability will correlate with the
no,
amount of
that
blood loss.
no, that will be there in both the patients.
Yes.
Sometimes in abruptio placenta, the bleeding might not be revealed at all. It will be seeping inside the myometrial layers, and it might cause a cubular uterus also. The bleeding might be too heavy,
Yes, ma'am.
and the retroplacental clots, it might even be around 1000 grams also. So in
Okay.
that case, the maternal compromise will be more only.
Yes, ma'am.
It's that's not a differentiating point. The color of the bleeding. What will be the color of the bleeding in abruption
Yes,
and
ma'am.
placenta previa?
Placenta previa will be a bright red color bleed, whereas
Yes,
abruptio will be a dull red color bleed.
it will be an altered red color, probably a maroon color. It will be like a maroon color. Okay, okay, uh, okay. Now, in case if the patient is a placenta previa,
Okay.
placenta is covering the internal loss. Now she has come with bleeding and 9 months amenorrhea. What will you do?
We'll
You are
manage.
not, that's what you have inserted two IV lifelines,
Uh,
started a crystalloid. If the BP is too low, you have to start, you take a blood for cross matching. You ask one
and
of the
blood
persons
transfusion.
to rush for blood, and every whatever bleeds, blood is the replacement for the bleeding. Until you get your blood arranged, till such time you can manage with crystalloids. If the BP is too low, you can proceed with giving them a colloid to stabilize the blood pressure. Okay, you have stabilized that patient. After that,
Ultrasound
yes, ultrasound is done.
and
It
always.
reveals a placenta previa, placenta covering the os, and the fetus is in good condition. Then,
Then we'll go for active management, ma'am. Active line of management. Hello.
mm, mm.
We can go for active line of management, ma'am. We
What
can't
active
do
line of
separate.
management you want to do?
Based on the location of the placenta, we can try either a vaginal delivery or a cesarean section.
EDD is 10/7, is it not? EDD is on 10/7.
Uh,
That's
we
what.
can go
What active line you want to do?
cesarean section, ma'am.
That's what. It is
Lower
the
second
central
cesarean section.
placenta previa.
Yes, ma'am.
Placenta is completely covering the os. Tell it boldly. You have to go for an emergency cesarean section.
Yes, ma'am.
She has already completed 30.
Ma'am,
She is in
it's breaking, ma'am.
39th week. Is it not?
Yes, ma'am. Now I'm able to hear.
Hello, Niveda? Able to hear me? Okay. Okay.
Yes, ma'am.
Her expected date of delivery is on 10/7.
Yes,
Is it
ma'am.
not? So she has completed 39 weeks. She has already completed 39 weeks, and now she has come with bleeding PV. So you can
Yes,
plan, already the fetal maturity is complete. So you can plan for an emergency LSCS in this patient. In
yes,
case the same patient has come in 28 weeks of gestation
yes, ma'am.
with bleeding PV and central placenta previa. What will you do?
Uh, Here we can go for
After,
McAfee regimen.
what
McAfee
is
regimen.
McAfee's regimen?
We'll stabilize the mother and the child, and because the lung wouldn't have matured yet, we'll give IV
Ah,
corticosteroids and
yes.
tocolytics like nifedipine can be given, and
Ah,
RH matching, blood cross typing, and a reserve of blood will be kept, ma'am. This will be
okay.
followed until 37 weeks, ma'am.
Most of the placenta previa, the bleeding will stop to recur again.
Yes,
Mostly that initial episode will stop, but there is a chance for recurrence again. So you have to keep the patient under admission only, under observation only. You cannot discharge the patient
yes, ma'am.
under your observation. You start her on IV corticosteroids for fetal lung maturity, and you wait for the you have to wait till the fetus gets matured. If the bleeding doesn't recur, and if there is any torrential bleeding, you have to intervene irrespective of the gestational age. But if if everything goes on well, you can wait at least depending upon your neonatal setup. In our institution, the survival is good after 32 weeks. So you have to wait at least for 32 to 34 weeks and then do an MRI scanning. Why should we do an MRI?
Uh, to check for placenta accreta.
Yes, to rule out whether there is any placenta accreta or percreta, because especially in this particular patient, she is a case of previous cesarean section. So the placenta might get percreta or accreta through the scar. So you have to rule out that also by doing an MRI, and then you can plan for an elective cesarean section. Okay, this is as far as placenta previa is concerned for type 3 and 4. In
Yes, ma'am.
case, if it is going to be type 1 placenta previa, what will you do?
Same McAfee regimen until 37th week, and then
Okay,
we can go for vaginal delivery.
yes, you can allow the patient for vaginal delivery. Okay. Uh, in case, if it's an abruption,
Okay.
39 weeks and patient has come with, you have ruled out a placenta previa. Placenta is in fundal position
Okay.
and there is evidence of retroplacental clots.
Okay.
What will you do? How will you proceed?
Uh, Immediate termination of labor, ma'am, through vaginal
How?
delivery.
So for that, what you should do?
Rupture of
You should
membrane.
do a
Because
pervaginal. You should do a pervaginal examination and assess in what stage of labor she is. In case if she is in too early a labor, only the cervix is 25% effaced and os is admitting only one finger, then what will you do?
we can try artificial
She
rupture
is
of membrane.
far from, no, at 25% one finger, she is too far from imminent delivery.
Okay.
Is it not? She
Yes,
is
ma'am.
in latent phase only.
C-section.
No, it is depending upon the severity of abruption. You have to plan your delivery. If the patient is anemic and if the retroplacental clot is heavy, or if there is heavy bleeding PV, and if you expect any fetal compromise, then you can plan for an immediate, and or if there is any maternal compromise also by the way of hypotension, you can plan for an immediate cesarean section, that too after stabilizing the patient. In case if the mother is stable and if there is only minimal retroplacental clot, then you can induce labor, because always a vaginal delivery is much more better, but you should keep monitoring the mother and the fetus. They should not be compromised in giving a vaginal delivery. If they are very stable, you can always plan the delivery in an institution, that too especially like us, having everything ready. The theatre is ready, blood is ready, and 24 hours obstetrician and anesthetist, neonatologist, everyone is ready. So you can induce labor if the patient and the baby fetus are stable. You can induce labor by cervipram gel, and then once the patient gets into active labor, you can do an artificial rupture of membranes. Can you give syntocinon for this patient? Accelerate labor with syntocinon?
No, ma'am.
Yes, you can go ahead. You can accelerate labor with Synto. In case if she is in active labor, as you said, you can go for artificial rupture of membranes and accelerate labor with Synto drip and deliver the patient. Okay. Once you have delivered, the patient has delivered, what will you do? You have to assess, you have to examine the placenta and assess how much retroplacental clot is there by weighing the clot. Okay, because you have to replace the patient adequately with the blood. What are all the complications of abruptio placenta?
The patient may go for hypovolemic shock, ma'am, and
Okay,
then there may be consumptive coagulopathy
ah,
and
that is the
renal failure,
most dreaded one. Then,
acute tubular necrosis, renal failure, ma'am,
yes, yes,
and if there may be postpartum hemorrhage,
yes, yes.
and
Because if you don't replace adequately for the losses immediately, the patient might go in for a disseminated DIC or acute renal shutdown. Patient, so you have to replace whatever till blood comes. Till such time, you have to replace the patient with either crystalloids or colloids. And if you have adequate facility for blood, yes, you have to replace it immediately with blood. If properly managed, patient will not go in for DIC or acute tubular necrosis, that is acute renal shutdown. So you have to be expectant of the complication and manage accordingly. Okay. So postpartum, she has delivered the baby. Will you do active management of third stage of labor
If
for a patient with abruptio placenta? What is AMSTIL?
active management of third stage of labor, ma'am.
Ah,
It has three components. First, IV oxytocin can be given to stop postpartum hemorrhage.
ah,
And after that, cord traction, controlled cord traction may be given, ma'am,
ah.
for delivery of the cord, and uterine massage is the third component.
Actually, it has three components. First is administration of any of the oxytocic drugs immediately after delivery of the baby. It is not oxytocin alone. It is
Okay.
administration of any of the oxytocic drugs. What
Okay.
are all the oxytocic drugs available?
Indestination.
Huh? Yes, ma?
Not sure.
Syntocinon, methergin,
Sin-
prostaglandins, and misoprostol. Prostaglandins is prostaglandin, E2 and F2 alpha. Everything is there. But we are giving only oxytocin. Oxytocin in a dose of, what is the
20,
dose of oxytocin we are using
20
for
international
AMSTIL?
units.
It is
20.
10 units. 10 units of oxytocin given IM intramuscularly. Okay. And how in one ampule of oxytocin, how many ml is there? It is for 1 ml. 1 ml of oxytocin is there in one ampule, and each ml contains 5 units. So you
Okay.
have to take 2 ml and give as IM. So we are giving only oxytocin because the other drugs like methergin and prostaglandins, they have their own complications. They had their own contraindications. In heart disease and PAH patients, this methergin is contraindicated. Again, in heart disease, you cannot, and bronchial asthma, not heart disease. In bronchial asthma and glaucoma patients, you cannot give prostaglandins. So, and in an institution like us, where a patient might come in full dilatation without prior booking and deliver immediately, we will not be having sufficient time to go through her records or examine her completely to rule out any heart disease or bronchial asthma. And if you are going to give inadvertently an methogen or prostaglandin, you will be precipitating a congestive cardiac failure. Whereas oxytocin doesn't have all these contraindications, hence it is the preferred one for AMSTIL. So we are using only oxytocin 10 units IM routinely. So after delivery of the baby, you are giving 10 units oxytocin IM, and then for what is control cord traction? It is for delivery of the placenta. Or will you wait for the placenta to separate after delivery of the baby? What are all the signs of placental separation?
That will be bleeding per vagina.
Bleeding per vaginum, fresh bleeding per vaginum. Anyone else? Anyone else also? Others also can answer. So fresh bleeding per vaginum, then there will be extravulval lengthening of cord, a suprapubic bulge, and fresh reappearance of pains. All these are signs of placental separation. In Amstel, will you wait for the placenta to separate for delivery, or you will start pulling it up even before the placenta separates?
We'll start pulling.
Yes, you should not wait for the placenta to separate. And but that is why it is called as control contraction, because if you pull it inadvertently, you'll land up in inversion of uterus. So after delivery of the placenta, you have to give 10 units of oxytocin IM, and after that you have to start pulling the cord by keeping one hand, left hand over the fundus of the uterus, stabilizing the uterus, and with right hand you are giving a control contraction to deliver the placenta. So once the placenta is delivered, you are giving uterine massage for the uterus to contract. These are the three components of Amstel, and this has reduced 60% of postpartum hemorrhage. That is why it is recommended. And you have to practice in both placenta previa and also in abruptio placenta. There is no contraindication to practice Amstel in all these cases. Okay. After delivery, you have to examine the placenta to see whether all the cotyledons are intact and to see how much is the retroplacental clot. Okay. Post delivery, whether it is a normal delivery or a C-section, how will you monitor all the a patient with placenta previa and abruptio placenta? What is the postnatal monitoring? With this, we can conclude.
Not sure, ma'am.
You have to keep monitoring the. You have to keep the. How long you have to keep the patient in labor ward? You have to keep them for at least 48 hours, because they might go in for DIC or abrupt renal shutdown anytime. So you have to keep them for 48 hours in labor room and keep monitoring. For the first 2 hours, every 15 minutes, you have to check the vitals of the patient, the contraction of the uterus, and the urine output and bleeding PV. And they should be put on continuous bladder drainage, and you have to monitor hourly urine output. And from the third hour onwards, you can monitor every hourly for 6 hours, and thereafter for every 2 hours for 24 hours. And then you have to keep the patient at least for 48 hours. After she is stable for 48 hours, you can transfer her to the postnatal ward. And what is the contraception you would advise?
IUD, ma'am. Intrauterine.
She is a second gravida. You can plan for a permanent sterilization. If not, can an IUCD be given for placenta previa and abruption?
No, ma'am.
It can be given, ma. It can be given. If there is no postpartum hemorrhage or if there is no ongoing hemorrhage, a PPIUCD can be given. Okay. Any doubt?
No, ma'am.
Okay. Thank you.
Everyone remain in the meet for 2 minutes. After